Welcome back to Sports Medicine on Tap. My name is Brandon O'Line. I'm sitting at Neck of the Woods Brewing Company with my good friends Dr. Frey and Dr. Bertha. Gentlemen, welcome back.
Thanks, man.
Yeah, thanks for having us.
Absolutely.
It's been a little while.
I feel like it's only been a couple of weeks.
It hasn't been that long,
But it feels like a very long time. Life has been busy.
I think maybe in part because we had a long hiatus, and then we just did one show, and then we took another week off.
Week off, right? It just felt like the last show didn't even really happen. But what a great show that was with Dr. Joanne Ballard from Rowan. So before we go into diving into tonight's topic, just a follow-up again from that episode last time. We mentioned
timing is everything.
Crazy timing, right? Is the story of Lauren Betts in UCLA women's basketball, how her mental health struggles, and she released this really cool essay about her story and all these other things. And then lo and behold, UCLA goes and wins the whole NCAA tournament, knocked off South Carolina in the finals.
Right.
Pretty well.
Dominant fashion.
Very dominant.
Yeah, they killed it.
Big game for them.
She's a big part of that.
And she put down a double-double on the box sheet, so she did pretty well for herself as well. I think that's a great way to go out as a senior, and with all that stuff. And I assume there was some publicity behind her essay and like things that could have gotten in the way, I guess, of just that all that stuff being public, but did really well, and they showed out for the tournament.
For sure.
Yeah, absolutely. She very much brought her A game, and they really did very well. So congrats to them.
Yeah.
And I think it's just a testament too of how important that mental health piece is, right? Because you would assume after all the things she's been through, she's in a good mental health space, and she able to like be laser focused, hit that flow state, and then just go out and literally ball out.
We like to think so.
Yeah, for sure. So tonight, I don't know how we made it this far without even diving deep into baseball, but we had to do a show on just kind of baseball around the horn, if you will.
Sure.
There's no blaring, super heavy names of
hangnails and stuff like that.
Yeah, nothing crazy.
Classic baseball.
Sorry.
So we just wanted to kind of get together tonight and talk a little bit about all these different things of some recent injuries, some people to look out for, of what's coming back, some comeback stories that are in the making, if you will. And we wouldn't be us without kind of starting with our home base here in Philadelphia to discuss Zack Wheeler's return, because when he went out last year and missed the remainder of the season, we kind of didn't talk about him or the Thoracic Outlet Syndrome that he was dealing with, and kind of what that was like, because he, if I remember correctly, like he pitched on whatever day it was, and the next day it was like, oh, yep, he's out for the year. And we're like, wait a minute, what's happened here? So we're going to dive into the discussion of Thoracic Outlet Syndrome. If anyone wants to kind of revisit some old episodes, we did talk about this, episode 51, about Steven Strasburg back in a couple years ago now. So we're going to kind of refresh that topic and talk about, his comeback and having his rib resected. And apparently he's keeping it in his closet too as well. He has the extra piece.
Yeah, is that true? Yeah.
I don't know. I don't know if it's true, but it's one hell of a story.
I got to tell you, because we're not really supposed to send that stuff home with the patient.
It'd make a great necklace, though. Could you imagine?
Right.
Very intimidating.
I'm not sure how that one shook out. I honestly, when I heard that, I was like, oh, no. People are going to start asking us to do things that I think are illegal.
Yeah, you don't want to take pieces home with you after surgery.
Right.
Yeah. No, I think this is, the Thoracic Outlet Syndrome it's such an interesting diagnosis, because it's always a really challenging diagnosis to make. It's almost a rule out diagnosis, where it's kind of one of these things where it's like, all right, well, we don't think it's any of the normal things, and maybe it's this. So it can be very, very tough. But I think we were talking a little bit, I think it's a little more common than we give it credit for.
I suspect that it is, in all actuality. Yeah, in all honesty. And, it's one of those diagnoses, and I hate to say this, that as a doc, on the doctor side, the doctor experience, and like this actually falls a little bit outside the realm of orthopedic surgeon. It's actually typically treated by like cardiothoracic surgery or even to some extent vascular surgeon. So it becomes tricky for me just in that alone. And it's one of those diagnoses that sometimes enters my mind fairly early and leaves my mouth later in the game, because it is one of those things I feel like people are like, what do you think it is, and like jump right on it. And then it is one of the things that, like, it is a challenge. Like there aren't always great ways to diagnose it. There's some risk in the tests sometimes that you use to try to figure it out if this is what's going on. There aren't great places to send. There's not a lot of people treat it, and it can be a real challenge. And people don't tend to do great if that's what if your goal is to return to throwing a ball 100 miles an hour for a living.
Right.
Yeah.
Doesn't always work out so well. And
Yeah.
everyday life different, but right. Yeah.
I think trying to get back and doing pitching is very challenging. And I think to your point, I think this is a diagnosis where often, much like a lot of people with hip pain,
right.
they get bounced around
a little bit
to a bunch of different doctors before someone actually says, hey, I think maybe this is what's going on. Maybe we should address this or try this. And like you alluded to as well, unfortunately, a lot of times this patient gets EMGs and things like that, which are not comfortable tests.
Yeah.
And it's a challenge. So.
And none of which is like people frequently like, well, why don't I get an MRI? And like lots of times it'll be normal, or like why don't I? Like there are different tests. Some will may be positive, some may not, but it's not like a lot of our other entities where like this is a problem, this is a test, now we'll know what it is. You know what I mean? Like it's a little bit of a tweener.
Yes, very much so. Now I know there is some true like diagnostic criteria that they have for kind of some of the
lay it on us
the neurogenic.
So different varieties, right?
Yeah,
it could be venous, it could be arterial, it could be neurogenic.
Which is crazy.
Sorry, go on.
Yeah, no, it's exactly that. It's one of those things you really have to kind of pinpoint whether or not it's kind of a vascular origin, and whether if there's an area of compression, is it the muscle, is it there an extra rib?
Right.
What is actually truly leading to that? Is it just a compression of the nerves? So there's a lot of criteria that go into that some of our other colleagues, oftentimes a lot of PM&R folks and things like that, are able to go through to give us a better idea. But I think what was it, Wemby, that had the vascular version of this,
right.
And then having this like more kind of neurogenic aspect is a little bit more common than the vascular one, but certainly both can happen. But it's a tough thing to come back from. And I was looking. A lot of the reports in the literature actually say there's a really high rate of return to sport. Talking like 80-90% rate of return to sport.
At the same
well, I was going to say that's the thing where the data looked like it got a little bit more fuzzy on. Was you really at the same level, or are you kind of at the level below what you came back to? So I have a feeling it's not quite at the same intensity that you are before. And and Wheeler coming back looking like maybe having a little bit of struggle from the get-go.
Yeah, he looked okay. I think at first he did all right. His one of his AAA starts, and then the second time he didn't look too great. And I think to go on like what we were talking about too, of like the diagnostic loopholes that you kind of go through with this, right? Especially in the world of pitchers, right? Good chance there's some labrum involvement just from their lifestyle of throwing, and then you go get an MRI.
Start thinking about that.
And then you're just like, oh, well, yeah, look, you got a labrum tear. Maybe that's a source of your problem. Let's do rehab for X amount of time. And that rehab doesn't go well. Then you're down this rabbit hole again of like, they're still not getting better or whatever the case is.
Is it their neck? Is it this?
Yeah.
Is it that? Yeah.
I think in pitchers particularly, it's really interesting because afterwards, there's a whole rehab protocol that they have really kind of focusing on minimizing the tension that you're putting through kind of stretching your brachial plexus here and trying to cause more injury to that. Yeah. So, they have to make modifications to how they pitch too.
Yeah.
And obviously that's going to impact their velocity.
Maybe that's part of the
accuracy.
issue of,
So.
Can you go through a little bit of like what the entity actually is for the most part?
Yeah, I mean, I think in general, essentially, there's some sort of compression that's happening on the nerves as they leave your neck and traverse over to your arm.
Yeah.
And, kind of the most common one, and the one that Zack Wheeler had, is having this extra accessory rib that is compressing upon those nerves. So when you get in a position that starts stretching those nerves, you're getting an additional version of compression on that. It's causing numbness, tingling, pain through the arm, and anything like that is going to start affecting your pitch, or really any overhead sport that you're trying to do is going to put those nerves really on a lot of stretch and cause a lot of pain. So, but that's kind of the general idea, is that you're getting a I guess what I'll call a dynamic compression of your nerves.
A constriction point, and that anterior triangle, or wherever it winds up being, and like again, it's slightly outside of like my specialty, but I remember like it can happen at a couple different points along the chain as you work down the kind of the brachial plexus in the front of the chest. Yeah. You can have above the rib, behind the rib, below the rib, and so a lot of variation, a little bit tricky. And then I guess it's not going so great for Zack Wheeler just yet.
Yeah, not yet. He's not out of the woods yet, if you will, and he's got a little bit more time. I don't know. I didn't really find a good article saying that like when his projected return is going to be. I mean, he's got to still get his workload up. I think he pitched so far like in a 3 inning outing. So it's just, he's getting his work up.
I mean, it's early.
Yeah, it's very early. Yeah. I mean, if I would say let him take his time till June, if not longer, or whatever the case is, trying to just get him ready for down the stretch. And hopefully the Phillies make playoffs, and that's when we have him in prime time and when he kind of catches his stride a little bit.
Yeah. Hopefully he keeps coming around. When do you know when was the surgery?
That's a great.
I thought it was pretty early last year.
Yeah, it was fairly early, right after kind of like when he went out. Whenever that, I think it was August or September.
Was it that late in the season?
I can live lookup.
Yeah, live lookup. Yeah, and so I think if we were to go, and I think it's one of those surprising ones where if you actually start to search and see like who has had this, it's probably more people than you might think. And we talked about Strasburg having it, but that was kind of at the end of his career. Like things were winding down anyway. But I don't think he had a super meaningful career for much longer after that, right?
Yeah.
And the guy that I always look at, or I always turn to when we talk about this, is Dark Knight. It's Matt Harvey.
Mm-hmm.
And part of that, we were just talking about it before this, like the unbelievable Mets rotation. Syndergaard, Harvey, Zack Wheeler, ironically, right? Like Steve Matz and DeGrom, and didn't do anything with it, right? Because someone was always hurt at some different point in time. And like Harvey and Syndergaard were like the guys, I think. Well, so was DeGrom. But then like, it ended. Like Harvey went, had the surgery, he came back, he still pitched. He was not the same guy.
Yeah.
It's and I just feel like I've seen that multiple times. So I worry for Zack Wheeler in this situation.
Yeah.
What are the chances of like the fact that you had two superstar pitchers coming from the same?
Right.
Yeah. And
Something in the New York water.
Yeah, something in the water. It's not just good for bagels. It hurts your shoulders too. But so I did look it up. It says September 23rd of 25. September 23rd, 2025 is when he had his surgery.
That late.
So I mean,
okay. Fair enough.
Really only about 6 months really out of that.
Right.
I mean, I think he's still got a lot of room to grow.
Lots of time.
There. Yeah. So hopefully good things to come for him.
Yeah. And these things turn out differently for different people, and you just never know how it's going to go. So you hate to sort of put that out there in the universe that it's going to be a tough comeback, but hopefully he turns into the Zack Wheeler of the last couple seasons here.
Yeah.
I think he was really like, didn't he say like he just wants one more good year basically? I think he's
kind of what he's looking for. So
we'll see if he can do it. I hope so.
And hold on, how old is he? 35. So yeah, I would say he's definitely on the tail end.
I feel like he came to prominence a little bit later in his career than maybe some other pitchers, and that was in part because of a series of like little knick-knack kind of injuries, little ding here, little ding there, and then finally in the last few years put it together and became dominant. Yeah. So he's older than we think.
It does make you wonder, though, what element of this that he's had going on for some time.
True. Good point.
Because it's not like the rip grew out of nowhere. I mean, it's been there all his life.
The whole time.
It's probably played some role into this. And, we were kind of alluding to the fact that I think a lot of these people go to a lot of doctors and you get a lot of different diagnoses, especially in pitchers, a lot of labral pathology. And I'm not saying that stuff wasn't there, but, it does make you wonder, was this playing a role all that time?
It is one of the mimickers, right? Like it does seem kind of like other things along the way, and like you said, it's somewhat the diagnosis of exclusion, where when it's not none of those other things, sometimes it's thoracic outlet.
Right.
Yeah, that's a really interesting point. It is.
And he's had other injuries too, like you said, I think late on he had Tommy John 10 years ago, give or take. So like he's had the. Then again, if Tommy John's so run of the mill anymore,
right?
It's such a almost normal thing, which isn't good, but it's almost like a rite of passage for most of these pitchers, unfortunately.
Which is crazy.
Which is a crazy thought, right?
Frequently, yeah. I almost feel like when trying to figure out if someone has thoracic outlet, that cervical rib, that extra rib is almost like I don't want to say a blessing because it's never that, but it's like oh, jackpot. We know, or not jackpot, bingo. We know exactly what it is.
It's identifiable.
I mean? Very identifiable.
Yeah, for sure. Because there's a lot of these folks that it's like.
Not sure. Could be, maybe.
Because they try some of these hydro dissections.
Yeah.
And kind of open up the areas around like your pec minor and things like that. And I feel like those are a little bit more nebulous because it's hard to truly articulate and say, oh yeah, your pec is a little bit tighter than what it should be.
Right.
But something to you have an extra rib.
Yeah.
That's a little more concrete.
And that's what I'm saying. Like it's a hard one to diagnose. And some of the like you can do a venogram. You can do a venogram with in the arm in different positions. Then you can do like an arteriogram. There's major risks with that, risk of stroke. So they're like, it's not an easy diagnosis. There's a lot of factors that go in, especially the vascular variety, which is less common. Maybe because it's harder to diagnose. I don't know.
That's hard to say.
Yeah.
So we'll see what happens, and I think early reports were saying that they want him. The Phillies kind of want him in the rotation sometime this month in April. I would imagine.
In April.
Yeah, that was like an early report that just kind of popped up when I was looking up his stuff just now. But
right.
I don't know. I mean, if he's doing a couple innings in AAA, hopefully he can kind of get his stuff up. But if he's also not doing so great and his velocity isn't there yet, I don't think they're going to rush him back.
They pitchers and catchers report 2 weeks before baseball, before the field report for a reason. These are healthy guys coming back to stretch out their arms. Mm-hmm. If he's just thrown 3 innings in AAA,
right,
he still really has to stretch out that
He's still
I don't know. I think April is optimistic.
Yeah. For sure.
I would agree. That seems pretty early. I'd be surprised, but we'll see.
We'll see what happens. To now go around the MLB a little bit more, we're just going to go down this list we have here. The good old oblique strain. Mookie Betts from the Dodgers went down with an oblique strain 2 days ago. Is on the 10-day IL, which is, I think it's a bit of a short timeline to put someone on for like an oblique. Just saying it's going to take about 10 days. I think. Yeah. With the world of rotation in baseball and being a hitter, I think that's going to be kind of hard to come back from that quickly.
Yeah, I agree. I mean, I think that whole body rotation that you're doing, that trying to get in after that oblique strain, it's going to be another thing. It's going to really affect your power.
Yeah.
I mean, I'd be inclined to agree with you. I feel like 10 days is a little bit fast. I guess it's one of those things. Do I feel like you can get back at 10 days? Sure, maybe. Do I really feel like you're going to get back and really be as effective as what you were? I feel like probably not.
Yeah.
I think it's a product of the sport, actually. I feel like MLB, they use that 10-day IL all the time.
Oh, yeah.
And I think it's more because they want to have the option to bring you back. But I feel like you see guys on the 10-day IL for like 3 months, like all the time.
It's like a renewal contract. You got another 10 days.
Literally, I think that's what it is. They just kind of keep renewing.
Yeah.
And so I agree with you, especially for in baseball, that nagging. I feel like this is really the only sport that we frequently see this injury too, right? I'm sure it happens in other sports, but like we really focus on it in baseball. Yeah. But I think it's gonna be longer.
And you see it like it's almost kind of a classic telltale sign, if you will, of like you see them take a good hard swing and they kind of pull up a little bit. They might grab their side or whatever. They just look really uncomfortable, and next thing you know, report comes out they're on the 10-day IL.
Yeah. I think to your point, Steve, I think baseball is probably the only real sport that you're doing such forceful rotation of your whole torso that's kind of causing strain through that. Like you said, you've seen it in other things, but I feel like it's more common in baseball.
And it's like kind of like a set start and finish. Like you're standing in the box, you're swinging in the same way. Where yes, the rotation does happen. You see it in football, but it's like could just be awkward. Yeah, golf.
It's a little bit different. Still.
Yeah, a little different for sure. But it's in the other sports. It's more of a different, I guess,
mechanism. Hockey, you see it somewhat, and sure enough, that resembles it a little bit.
Yeah, that's true as well. And then from the other side of it, and still regarding the oblique strain, is Spencer Strider from the Braves is also dealing with it. But apparently a few days ago he had a quote-unquote good bullpen, and he's on his way back. And I think, again, from pitchers, we talked about hitting at first, but pitching is also very much rotational, and depending on which side it is and how things are going. And I think we talked about the Braves a lot last year and their injury-rattled team. And I think they're already starting to be snake bitten early on.
Is it really? It's happening?
I think they're happening a little bit more with just some other things. I don't have everybody on the list, but I think they're already starting to look at some injuries already. It's just like, oh, here we go again.
Yeah, right. That's going to be tough. Another tough year coming.
Yeah. Personally, I don't mind it. If there's a team that's going to be decimated a little bit, not that I'm wishing any injury on anyone. As a Mets fan and in the Philly area, man, the Braves have been so good for so long. Yeah. Not so much it's just recently, but like, and if they're healthy, they're a tough team again. Yeah. So I feel like he himself, Spencer Strider, was on the cusp of like stardom, and then it began to unwind. Injury, and like injuries beget injuries to a large extent. When you're not out there playing, you're not out doing it every day, you're not out there, and then you start to lose whatever it is, a little bit of conditioning, and then you try to get back, and maybe you tried to push a little bit too much or a little bit too soon, and then the next thing happens, and then you're deconditioned further. And I feel like he's been victim of that. And if he could get it all together and get back there, he's a legit pitcher.
Yeah, for sure. And I think that was like his big thing because I think last year, I think he went down with Tommy John.
Was it Tom? I feel like was there an ACL? Like I don't remember. There's been a few, like 2-3 years in a row, like as he wound down what was otherwise like his burst onto the scene as stardom. I don't know.
Well, I feel to your point, I do think there's a lot of these folks, especially in any professional athletic setting, where we want to push people to get back so fast and be able to do what they need to do. And, you rush them back in and then they got a setback and then they got this up and down that they do. And I think in most people, it kind of ends up being, up and down and then kind of fizzle out.
Yeah.
And that's the thing is, in so many of these sports, the actual duration that you're in, it's so short.
Yeah.
Because, it's just such a high impact activity. You're getting so many injuries. I think they say in the NFL, the average span in the NFL, I think it's like 5 years or something like that. Maybe less.
I think it's less. Yeah, that's like a good career.
Yeah, and it's one of these things, but it's just you get so beat up, and if you can't recover, you're just going to just take a beating.
Yeah, for sure. So to go on to what you were talking about, the Mets as well, with their big offseason signing with Juan Soto, went down with a calf strain, and that's not something you want to see from your big off-season signing.
Well, that's 2 years ago. That was the big one.
Was it?
Yeah.
Wow,
yeah.
was that quick?
I know.
But
Bichette was this past year.
Right. And he's also not doing so great either.
He's turning it around.
But he'll figure it out,
Sorry.
right? But with the calf strain, which is always interesting, and it's always like I don't know. I think in general, I always get a little cautious when you start having calf problems early on.
Yeah.
Early on too, and I guess to almost take back what I said, I guess it would be better to have it earlier on than down the stretch when you want to make that push for postseason and then you push it too hard and then you end up like we've mentioned how many times the Kevin Durant situation where you're pushing through a calf, or the Tyrese Halliburton in the finals, Game 7, he goes down.
Don't even put that out there in the universe.
But at least in the beginning of the year, you have the opportunity to take some time with it.
Yeah.
And you hope that it doesn't become a long-term issue.
Yeah, exactly. And that's what it is. Like these very frustrating, annoying injuries where you think you're better and then you're not, and then in the worst case scenario, like disaster strikes, and but they're nagging and they come back and they tend to haunt you, and then some of them sometimes you heal and you're better and that's it and that's the end of it.
Yep.
And sometimes you're plagued for the rest of your career by this thing that just keeps sort of coming back. It's,
very much. It's these posterior chain injuries. You get these calves, you get these hamstrings, and they just keep coming back. They just don't go away. But they're tough.
They're pesky returning injuries that always kind of haunt you unless you address it really well, really early, and you kind of miss that re-injury rate window. So then we'll go to Hunter Brown of the Astros. Their young ace went down with what's being reported as a shoulder strain, which is something that I thought was interesting. And I always like kind of taking these opportunities to go through the weeds a little bit on what your guys' thoughts on what this broad term of a shoulder strain could be.
Yeah, I don't know. It's always so hard because it's like what does that mean? And I feel like in a lot of especially baseball, I feel like more often it's kind of like rotator cuff kind of tendonitis kind of thing, and that's what they're really straining, and that's where a lot of the irritation is coming from. Yeah. But to your point, it's always like I don't know what that means. There's so many structures, there's so many things that it could be. It's so vague.
Yeah.
I think of this as the flexor tendonitis of the elbow. Do you know what I mean?
Yeah.
And like every time that guy has flexor tendonitis of the elbow, he's getting his ulnar collateral ligament done, 2 months later. And I worry that anytime, whenever I hear, lat strain, oh no, right?
Yeah.
And shoulder strain, oh no, where is this headed? Or is there? I don't want to say putting their head in the sand because that's not the right answer. Are those the first warning signs? And they're just trying to get this guy through it. But sometimes they do. I just feel like more often than not, they don't. And then it winds up, they're getting whatever surgery to fix it.
Yeah, and I was going to say, the outcomes, especially in MLB players that have rotator cuff problems, the outcomes are not great, especially if they have surgery.
Yeah.
It's one of those things you're almost, I think the data shows you're almost better off not doing any surgery and just dealing with it until you feel like you're kind of at the end of things, because you're not going to do well coming back from it.
And I will say this, I think we see the shoulder strain that winds up being nothing way more often than we see the flexor pronator, tendonitis
Agreed.
that winds up being nothing. So hopefully that this is actually just nothing. And there's a number of different things it could be for the shoulder, right? Like that actually aren't serious or significant. You just, the red flag goes up as soon as you hear that.
Yeah, absolutely.
And especially early on for a young guy, it's like, oh man, I hope they don't try to push this younger kid too hard, or vice versa. They take a little bit of time, and hopefully it's
give him his time.
Give him his time. If you want him to be your young ace, you take care of that ace, and you don't want to beat it up too early.
And it is sometimes it's the pre-drome or the prodrome, right? Like the shot across the bow, like hey, you don't have a problem yet, but if you don't make a couple changes here, if you don't take your time, you're gonna have a real problem.
Yeah.
And then sometimes like once you've had the slap event, right? Like the tear, they actually like now it's happened. Now you can't slow down and just make it get better that way.
Yeah, no, absolutely. And I honestly, I think in baseball pitching, almost more than anything else, because it's such a whole body movement, when you start changing the mechanics of one spot,
it's true.
Everything else starts changing, and then you're just risk of injury, of
somewhere
whether it's
else,
these obliques, the elbow, the hips, all these things that just kind of play into each other. So
you got to make up that little bit of missed force from somewhere.
Yeah,
right.
You got to come if you're throwing 95 miles an hour and you get something wrong and you're only throwing 90.
Yeah.
You're going to try to push those extra 5 miles from something.
Exactly.
And the next thing you know, that's going to be the next overuse injury that you're dealing with.
And it is amazing how like 2 or 3 miles per hour velocity is like the difference between successful major league pitcher and career minor leaguer. Like, you know what I mean? Like it doesn't hold true across the board, right? This guy can throw 95, make the majors, but at or let's say this guy throws 98, he can make the majors. But at 94 or 95, he's a minor leaguer.
Yeah.
The next guy can only throw 95 and he's in the majors. Yeah. But for him, 93, and it depends on how much movement and how much spin and all these other factors. Right. But for on an individual basis, these guys start losing a few miles per hour, a little bit of velocity, it all tends to unravel.
Yeah, for sure. Yeah, it's a big difference for just a small velocity.
Right.
For sure.
That, and I think also with the way baseball's going, you're getting just so many people throwing 100 miles an hour.
It's amazing.
It's crazy how, and I think at least this year, I don't know if you guys tuned in for the World Baseball Classic.
It was great.
It was great to watch, but then also
great.
Seeing these guys who may not be in the majors yet just go up there and they're throwing 100. Like, who's this guy? He's just a regular day pitcher from Japan, and now he's just out here throwing 100 miles an hour.
Yeah.
Or like there was some I forget whose son it was. Played for they played the USA, I think, and he went up there and he was like 17 years old. Playing the World Baseball Classic, he struck out Aaron Judge a couple, like whatever the case was. Like. It's just it was such a cool showcase of all these different talents across the world. But again, it was just like, it was amazing to see how many people just throw 100 miles an hour, where 10, 15 years ago,
it was rarity.
Chapman,
huge rarity.
Yeah.
Like, you're like, oh my God, he hit 100. Now Skeens throws like 17 of 20 pitches.
Yeah.
Right.
Over 100.
Now, what's your thought, not to get too much into the weeds, what's your thought on having the whole pitch clock? Do you think that's going to increase rates of any of these injuries? I know some of the early studies and monitoring of this hasn't shown really much of a change, but you think it's a matter of time? Do you think it's probably not a difference?
I don't know. It's pure speculation. Logic would dictate that maybe it would potentially do that, increase the rates of injuries. In reality, I don't know. I guess probably not.
That's kind of my feeling as well. I feel like this is kind of like the whole like statistical versus clinical significance kind of thing. Like, you know, maybe, in a huge setting, maybe there's some sort of statistical difference, but I feel like as people do it, it's probably not anything that's going to be that meaningfully different.
Yeah. And I think we surpassed the point of where we would see the difference. I think the first year is probably the best chance of you seeing an issue with it, because it's a whole new stimulus to the system. And I think the biggest part was like, my biggest worry was recovery time for these pitchers who would take a little walk around the mound and take their time to kind of catch a cool, then throw. Now you have a set time, and I think at this point, most of everybody, at least the game of baseball, kind of adapted this pitch clock across the board. We even have it in the college world. So I think the baseball athlete has now adapted to this time change. And I think the first year or two, you would have seen that spike if there was anything.
It can wind up going in a direction like that you totally don't expect, right? Like maybe before the pitch clock, like you said, a guy buys a little extra time, gets a little extra rest between pitches and whatnot, and then throws an extra inning or an inning and a half, and then is more apt to get injured. Whereas when he runs out of gas now, he's out of gas and he's out. Yeah. So he's done before he can hurt himself. So like it's weird like how it's going to wind up shaking out. And we talked about this. We did a show actually when they started cracking down on the bullfrog and this all the sticky device different things like the guys are using, and like is this going to lead to more injuries because now they have to grip the ball harder when they throw it. I actually don't know if the follow-up study was ever done. If we're thinking about studies, to see. I guess we'll see. You just never know.
Yeah. Like I said, I think
we had Greg Burke on for that.
Yeah, we did. We did have that discussion.
Yeah.
So now to go down to we've kind of alluded to it. We touched on the Tommy John stories, kind of Tommy John tracker, if you will. Kind of two cases in the majors right now. Gerrit Cole and Joe Musgrove from the Padres. Gerrit Cole from the Yankees. Both had Tommy John, but kind of different trajectories right now. I don't know exactly. I think they had it kind of like in the 2025 season. But Gerrit Cole's looking pretty good and going on a good pace, and Musgrove's on the kind of the opposite. He's not doing so great. Started the season on the IL because he was having some pain in the elbow. Ended up getting shut down for a few weeks. And as of now, like I think the most recent report is that he's only playing catch right now. He hasn't touched a mound. Whereas Gerrit Cole's throwing some bullpens, and he even pitched in I think a total, not all in one setting, but a total of 3 innings over the course of spring training for the Yankees. So it's one of those things of, how crazy and how different this Tommy John surgery can go for different people. You can have success stories. You can say, oh, yep, you're good. You kind of miss your year, if you will.
Right.
And then you're back the following year, no issues. Or you kind of miss your year, you come back, and then it's not the same.
Never. Yeah.
I think it's the suture augmentation that Gerrit Cole got.
The internal brace. Yeah, it's okay. You can say it's okay.
There's a whole controversy of whether or not this is truly beneficial or not of adding this extra suture that crosses it with the internal brace and whether it doesn't. The Arthrex company, they got a lot of data that suggests that it does. It suggests it helps.
We've mentioned it in many other surgeries and recoveries and whatnot because it is a big factor. It changed the world of orthopedics.
It is. It's been a big thing, and that's I don't know. I do think it helps. Does it? Is it going to allow someone to return and not return? I don't know. I mean, it's one of those things. I guess the data will still be out and will remain to be seen. I think it's really interesting for these Tommy John surgeries because it's such a small group of orthopedic surgeons.
It's true.
That actually does this procedure.
Yeah.
It's one of these things based on where these people are at. It's like we kind of know who does these procedures in that area and who's
super specialized. Yeah.
And even for them, like they only do. I'd say, when I was at the University of Colorado, we had one doctor out there that worked with the Rockies, and he's like the UCL guy there, and he's like, I think I do maybe 30 to 50 a year, which is not,
that's a huge number for that injury.
Yeah,
right?
For that injury, it's a ton. But if you think about it in terms of, like volume, it's still not that
a huge number.
Right.
Yeah. It's kind of crazy, how just infrequent of an injury it truly is, and where this data comes from and everything. So
I did my fellowship out in Pittsburgh at Allegheny, and there were team docs for the Pirates, and even with that, again, relatively infrequently. Mm-hmm. Saw a few, helped out on a few, but wasn't like by any means like a huge part of the practice. It just they're pretty infrequent, and they just like you're saying, they become very, very specialized. And even within our group, right, we have. When I see them, or I'm even concerned about it, I send him for us. I send him to Dr. George, who's in our group. Yeah.
It's such a small portion of people that do it.
Yeah.
I mean, we have the benefit. We have Dr. Sakati here, over in Philly.
In Philly, right? Yeah, of course.
A ton of them,
right.
One of those
big
things,
name in that. Yeah.
Yeah, no, it's such an infrequent injury, but it's very interesting from that standpoint. I think it's one of those sports injuries that I think you really have a few specific physicians out there that really actually deal with it. And everyone else kind of dabbles a little bit.
Right.
Yeah, that's a good way to put it. And I think my biggest issue, I would say, with the internal bracing is that it kind of takes away from the opportunity for these sub-elite athletes, the ones that aren't, the D1 who are going to get drafted, or like the guys who are D2, D3, or just decent high school athletes, if you will. I think this internal bracing has given them a bit of a false hope of like, oh, I'm going to get back in X amount of months now, versus where traditionally when you had all that time off, you had the opportunity to correct a lot of imbalances and improper mechanics or whatever the case is. Now that time shortened, and they kind of not set up for failure, but they kind of treat their rehab as like a marker. Like, oh, I'm going to hit 8 months and I'm going to be on a mound again. It's like, well, let's not go crazy, and let's kind of like have a reality check of like, you're not that high of a caliber athlete. You might need some more time to kind of correct all these things which got you in this situation in the first place.
Right.
And I think that's like the biggest pushback from this internal bracing, at least I've seen on my end, of like
people pushing it too fast.
Pushing it too fast, too soon. It's like, well, now we're going to have more problems, or we're going to still have kind of like the Musgrove situation. You're going to try to go do too much, and then you're shut down again because you're having elbow pain again.
Yeah. And like, full disclosure, that brace is not meant to, the internal brace, that suture isn't meant to replace the ligament.
Right.
It just shares the load. It supports the ligament until the ligament heals and is able to do the job on its own.
Yeah.
It's only a matter of time before that sucker fails if the ligament doesn't take.
Yeah, no, for sure. And not in an elbow world, but in a knee world with ACLs where we're doing the internal brace, it's not an uncommon complaint that people often, what I see around 2-year mark, people feel a pop.
Yeah.
And it's that suture tearing, and it's very unsettling because it's like, well, what happened? Where you're losing stability of your knee, and where's it at? So I think there's an element of that too. If that area tears, there's very much of, partially stability, but also a mental component of, well, now I felt a new pop.
Panic
like, is
time.
something wrong? Yeah, what's going on?
Yeah, you definitely don't want to ever feel that again.
No.
Sure.
You know from experience.
Yeah, I never want to feel a pop in my leg ever again in my life. I don't want it. So to kind of wrap up a little bit here, our last topic on this is good old specifically, Justin Verlander. He had a little return back to the Tigers at the age of 43 now.
Guy's amazing.
Yeah,
right?
We've been around forever.
Right.
For a long time. But however, he's ended himself on the IL with some hip inflammation.
10 days.
And 10 days, and unfortunately, he's kind of the old guy having some bad hips. So he's a right-handed thrower, and it's reported that he's having some left hip inflammation. So just kind of wanted to take an idea on what that is. That's his like landing leg. So I figured that leg has been through a lot over the years, and a lot of force has been transmitted up that leg and into the hip. So what do you guys think?
Thoughts?
Yeah. So I definitely think it's one of those things, especially in the 40s. You get a lot of early degeneration of the labrum, maybe even some early cartilage thing. It's very common in athletes like this, especially baseball players, to have what we call a cam lesion about their hip, and that causes some impingement and causes some inflammation. So I wouldn't be shocked if, as time has gone on, that's become more symptomatic and become more problematic for him, and just starting to lead to a little bit more pain about his hip, especially when he's doing those high flexion moments. And I think it's probably one of those things. He'll probably get it calm back down in 10 days, of course, and start to feel good again. But I think, again, much like some of these other injuries, I think it's one of those things that kind of culminates on itself, and just it's going to keep kind of ebb and flow as we kind of go through and keep worsening. And at 43, you've played a lot of good baseball.
Yeah.
Right. Maybe there's not a whole lot left in that hip.
Yeah.
And I, if let's say it is that pure speculation, right? Like there could be 10 other things, which is one of the reasons why treating hips is so challenging, because it can be 10 other things. They all present very similarly. But let's say that's what's going on here. He's 43 years old. Would you like typically the right answer, someone who has femoral acetabular impingement, this cam impingement, maybe the labrum is affected by it. They get a hip scope, you shave it down, make it look like more of a normal hip. Is this something that you do when somebody who's 43 years old, especially if they're still trying to pitch?
Yeah, so I think it's definitely a controversial topic, because I think, especially in the years past, I think doing a hip scope and addressing some of these labral pathologies and femoral acetabular impingement pathologies was much more of a young man's game, so to speak.
Right.
Teens, 20s, maybe in your 30s.
Yeah.
There's a lot of growing evidence, though, that if patients really do have minimal arthritis, even in their 40s and 50s, they can benefit from having this procedure and getting things fixed up. So I think that it absolutely is in the realm of something that can be improved. That could be, again, purely speculation of that being it. But that could be helped from a surgical standpoint.
Right.
The question is you do that, it's a long recovery.
Yeah.
At 43,
the career is probably over.
Yeah. Do you ever really get back? Probably not.
Yeah.
You probably play it out until you're like, I can't tolerate it anymore, and go from there. But
and this is probably not a question that you can answer. It's a little bit of an unfair question. But let's say that's what it is. There isn't that much arthritis. About how long do you think he has until there is arthritis, and now you've missed your boat on the ability to try to correct it?
Yeah, that's
again, not a fair question, like just to speculate.
No, it's a great question though. I mean, it's one of those things. Obviously, it's hard to say, what the progression will be, but there's good evidence that shows when you do have cam lesions and femoroacetabular impingement, it does increase your rate of having arthritis. And if he has minimal arthritis now, there's good literature that suggests that addressing that can probably provide 10, 15 years more of your regular native hip.
But
longer.
On the flip side of that, like, can he get through the year and then do it next year, or is he putting himself at risk of missing the boat of the ability to do it?
Yeah, the timing wise, hard to say.
And I don't know that there is a right answer.
Yeah, I was going to say hard to say from that standpoint. I don't know that I could give a good speculation. I mean, my gut feeling about it is probably not gonna, in that time span, especially at 43, probably not going to have as much of a long-term impact. You probably could wait a little bit.
Yeah, a little window.
But hard to say.
Yeah. I feel like, because we get that question as docs all the time, right? When people are in season and like, hey, what if like summer's approaching, can I do this in the fall? And sometimes the answer is yes, and something like a root tear, lots of times, a meniscus root tear. I don't know if you really want to wait. And so I don't know how touchy these ones are. My gut is, and it's just purely gut, is that you're right, that you probably have a year or two to kind of dabble a little bit. Things may get a little worse over that period of time, but maybe you're more likely apt to tear your labrum if you haven't torn it already, as opposed to getting arthritis in that period of time.
Yeah.
But if you ignore it forever, I think you got a problem.
Yeah, absolutely. And again, I'll shift back a little bit to some of the ACL stuff, because that's where a lot of the good data is. And I know that there's some studies that says for that, probably delaying up to 6 months is probably okay. To prevent having further damage to your meniscus and cartilage. But there's not really great literature from a hip world to say is that similar or not. But it's the best comparison we probably have from that standpoint.
Study time.
I got more. We got lots of research.
Fodder everywhere.
So, to kind of another question for that, is there anything non-surgically to do for this hip inflammation if it is arthritic? All right, so say it's not arthritic right now. Is there anything that you're doing, injections, just treatment, physical therapy? What is your thoughts on the best course of action if the goal is to get this 43-year-old man to get through this long season, and it's already 2 weeks in and he's already on the IL? So what are your thoughts on that?
Yeah, I mean, I think especially for the layman, obviously physical therapy, some of the activity modifications is always a great go-to. Getting those abductor muscles and external rotators stronger is going to help provide some more stability to the hip flexor strengthening, all those kind of things that can be very beneficial. And someone that probably has, I would assume, relatively good strength, but not always a given, I will say.
Yeah.
Not always a given.
Shocking.
Yeah, it is shocking from
100%.
that standpoint. But getting past that, certainly injections can be really helpful, especially if you're trying to get through the year. Mm-hmm. Steroid injection can be very helpful. There is some growing literature and growing evidence that PRP can be really helpful for these patients. And I think I will say, anecdotally, I see a lot of patients that get PRP for hip arthritis and hip femoroacetabular impingement, and they seem to do very well.
Time. Yeah.
Especially if you're looking for a short-term, 6 months, a year, 2 years kind of time span. I think you can do very well with some of these things, kind of mitigating it out for a period of time. So I certainly think something in an injection standpoint could be very beneficial for him.
And we've talked about it multiple times, right? There's something to the biologics. There's a role to the biologics. We don't fully understand it yet, but it's becoming more and more a part of medicine.
Yeah. And I think as more the research takes place, where we have a much more standardized process of doing that, I think is where we're going to really start taking it out. And I don't remember all the specifics of what the platelet count would be and everything like that. But as we get things that are like, okay, you're getting what he's getting and what you're getting, and it's all the same, we can really say, hey, this PRP is really working, as opposed to saying, well, maybe you got 1 million platelets and he got 10 million platelets. There's a big difference.
Yeah, so, leukocyte rich versus leukocyte poor versus all the different systems.
So I think we went around the whole league, if you will, and talked about a little bit of everything. Anything else before we close out here tonight, gentlemen?
Yeah. Beer.
Sourfest, right?
Sourfest, sorry.
For any of the folks who are local to the South Jersey area or Pennsylvania, Delaware, if you want to check out Neck of the Woods Brewing Company Sourfest, it is this year, May 16th, here at Neck of the Woods in Pittman, New Jersey, at the Total Turf Complex. Come back. They have a lot of good things. They have bands. They have games. They have, I think there's some prizes involved. Some
a lot of
trucks,
good beer.
A lot of good beer.
A whole lot of beer. I think they're up to almost 30 sours on the list with some seltzers. And, of course, all their classics, Stay in the Car Franks and other things are going to be available on tap as well. So get yourselves over here. And I believe the pre-sale's going on soon. And there's some, added benefits of getting your tickets ahead of time. So go on the Neck of the Woods website and check that out. And then lastly, before we close out our tab, a last shout out to our sponsor, Timber Productions, and our guy Kyle over there helping us get all this media out to all you awesome listeners. So give us a like on social media, on Instagram, and follow us on YouTube, and we'll see you next time, folks. Have a great one.